follow.
Thank you. Dr. Messaoudi? See, I could do it.
So yeah, I guess I've different kind of week than Cindy and probably what Mike will share about his week, but I am working really hard with a lot of our UCI investigators in the School of Medicine, the School of Nursing, and Public Health to really get some projects off the ground so that we can better understand the reach of this viral infection, the mechanisms of pathogenesis, and get a better handle on the way that this virus is behaving itself. So just to give a few insights into the kinds of projects that we're hoping to get off the ground, we are gearing up to do some surveillance work in healthcare providers and the community. We're also gearing to do some experimental work in animal models to try and understand why older individuals have a more severe disease. And we're also gearing up to set testing abilities, both from a antibody perspective as well as viral shedding in the lab. So we have all those experiments that are all happening all at once in the lab. So it's been a very busy week for me too, from a different point of view.
Thank you for digging in and doing that research. I know there are a lot of questions about the research that we will come across. How about you, Mike?
Yeah, so I think Cynthia used the word tumultuous, and I think that's very apt for kind of what my last week has been. Not only both, sort of as the front lines as an ICU physician, but then we sort of have the added challenge of the unpredictable nature of our manpower. As I'm sure many of you know, the Mercy is now in Los Angeles Harbor. That took 950 personnel from our hospital. In addition to that, there are multiple expeditionary medical forces being deployed throughout the nation, taking other physicians, nurses, and support staff from our hospital as well. So we are doing our best to determine exactly what our capacity is while simultaneously caring for the COVID patients that are already present. And we still don't know how many physicians, nurses, beds, et cetera, we will have to kind of combat this coming epidemic as it ramps up over the coming weeks.
Can I just ask a question? This is Eric Perlman with Susan.
It's not time.
No, on that note, Mike, you said that there's hospital personnel that's going to the ship.
So the Mercy is entirely staffed by Navy personnel.
Okay. But that includes medical staff, of course.
Correct. Physicians, okay. Nurses, corpsmen who are sort of like medical technicians. And then of course there are, the folks who are needed to help support those people, like cooks and people to clean and do laundry and all that sort of thing.
But they're not taking any personnel from the hospital.
Absolutely, they are.
Absolutely, they are. Okay, so how many
those 950 people are nurses, doctors, corpsmen from my hospital, from my department, nurses from my ICU. Our two bronchoscopy technicians from our department are both on the Mercy. So we're operating with an extremely depleted labor force, and it's only going to get worse moving forward.
Isn't this kind of defeating the purpose of bringing the ship here?
Well, yes and no. I mean, the idea is that the ship can help respond to, some of the more intense areas of clinical outbreaks. For example, we're sending a group to New York as well to help there. Does that put our hospital at a little bit more risk? It certainly does, and that just causes us to who are left behind to have to step up and work just that much harder. And that's sort of the culture in the military. That's what we do.
Mike, there's a question about, you're at the Balboa Naval Hospital in San Diego.
Right.
Okay.
Great. Thanks. So let's jump into our questions that have been provided for us. There are, Cindy, we talked about a limit of 10 the last time, and we have now brought in several more people, so we're going to go a little bit above that, but let's try and move swiftly through them. What things are actually known for certain regarding how this is actually transmitted? And it continues, is it only close personal contact, aerosol hanging in the air, touching packages, food at the store, door handles, sitting on a bench, etc.? What do we know?
So the good news is that we know more now that this is transmitted by respiratory droplets. And the primary means of transmission is from someone who's infected and symptomatic through a droplet, that is coughing, sneezing, speaking, and the droplet lands on the other person's mucosa, eyes, nose, or mouth, right? That's how it enters the body. Because this is respiratory droplet, it requires fairly close contact. We also know that the virus can survive on some inanimate objects. We call these fomites. These are things that maybe someone coughs or sneezes on, and some droplets land on a door handle or an elevator button or something like that. The next person comes along and touches that, picks it up, rubs their eye, and then they've contracted or introduced the virus into their system. The information about fomite transmission is still evolving. We know that the virus can survive to the point where it can infect others for periods of time in inanimate objects, up to a few days, right? But the time that it survives for transmissibility, it really depends on the conditions. That is the moisture, the temperature, and so forth, the type of surface that it's on. It seems the primary transmission is through respiratory droplets from person to person. And the good news is that droplets drop down. They drop pretty quickly. And on inanimate objects, they don't survive that long. And so a lot of the fear about this virus is, could it be on anything we touch outside? Could it last for days? The more information we're getting, the more we're confirming that this is a respiratory droplet spread. And maybe I'll ask Ilhem to comment, because it sounds like this is the type of research she may be doing now.
Ilhem?
Yep, I got.
Okay.
I mean, I have nothing more to add to what Cynthia said. I mean, this is, we're all coming to understand that this is transmitted via respiratory droplets. And I know that there was a concern about the New England Journal of Medicine article that showed that this virus can be suspended in the air for 3 hours and on certain surfaces for 72 hours, like steel and cardboard for 24 hours. But I just kind of want to, everything has to be taken with a grain of salt, and those experiments were done in very controlled laboratory setting. For example, they aerosolized the virus into a chamber that was then sealed, and then they measured the presence of the virus. So that's very, very different from a place where there is sunlight and there's air and there is other environmental factors that are going to change those conditions dramatically. So I thank you, Cynthia. That was really nice. I don't know if you have anything to add, Mike. Yeah,
very, very well said.
I kind of wanted, and the good thing about respiratory droplets as well, as Cynthia said, is that a surgical mask is actually incredibly effective because they are heavy and they drop. And so there are certain masks that are reserved for when certain procedures are done that create a lot of aerosols. But this is good news for the healthcare workforce.
Great. So the next question, thank you, all three of you. If we go for a walk outside around the neighborhood and we meet someone on a path, a sidewalk, we stand aside, but then walk down the same pathway, what is our actual risk of being infected? And I think you answered that pretty well, but do you want to just kind of circle the wagons on that?
Again, I would emphasize that the risk is pretty low. Unless the person that you're walking by sneezes in your face, it's unlikely that you're going to be exposed to transmission of the virus.
That's helpful, thanks. What kind of measures do we need to take to disinfect our food? This is a common question, and I think of it myself. Food delivery items, whether it's Postmates, DoorDash, even if it's a volunteer bringing in goods from another neighbor in the neighborhood.
Again, I'll just remind people to think about the droplets. And so, for example, if the food delivery person happened to sneeze on the bag before they drop it at the door, and you pick up the bag and bring it into your house, you would take the food out, you would wash your hands before you eat the food. Okay, so washing your hands is really one of the most important preventive measures that we have, because anything that we might touch that has a droplet on it, if we wash our hands properly with soap, 20 seconds, vigorous rubbing, that should eliminate the virus.
What about keeping our eyeglasses sanitary? Washing our hands, washing our eyeglasses?
So similarly, plain soap breaks down the viral envelope. Certainly any other disinfectants such as bleach, such as alcohol, 70%, those will break down the particle. So I like to use some dilute bleach solution in a spray bottle on a paper towel that I wipe down my steering wheel, door handles, all kinds of things. I'm a big fan of bleach, but alcohol will work just as well. I saw a question about Lysol. And I'm not exactly sure what's in Lysol. I think there's probably some alcohol there. My guess is that that would probably also break down the viral envelope. Maybe I'll ask Ilhem to comment on this.
So yeah, when we work with the virus in the biosafety level 3 laboratory, our disinfectants are actually 70% ethanol and 10% bleach. So it's actually a pretty wimpy virus. The minute viruses have envelopes, the bilayer membrane, that's a pretty wimpy virus. I mean, I'm not diminishing what it can do, but in terms of our methods of killing it, there's actually pretty good tools.
I'm asking Eric a question, and I'm asking you all. There's been a question about iodine, and if it appears to be as effective or chlorine dioxide for killing bacteria and viruses. So iodine?
I mean, so I don't know. I mean, iodine is used all for surgical preps, etc. I don't know that you want to go that far, and I think that to make proper iodine solutions, you have to have at least some training and some knowledge on how to prep most of these. And some individuals are actually also allergic to iodine, so you might want to be, if you have a safer alternative like 70% ethanol, a little bit of bleach and water, I think that's what I would do.
Great.
Yeah, I think iodine is unnecessary, and I think there are better, safer, easier alternatives.
Plus, it's harder to get a hold of.
Yeah.
So why bother?
So the next set of
clothes.
Sorry.
Yeah. It stains your clothes.
And it stains your clothes. That's right.
Okay. The next series of questions goes to medical treatment and immune response. Exactly how does the disease progress? If you have a fever less than 102 and body aches for 2 days, and the third day you feel a little better, can you rebound? Can you rebound? Can you get back? Can you get worse? I'm having a terrible time reading, sorry. I heard that after a few days, your immune system could go into overdrive and cause toxic shock.
So I think one of the things that's important to keep in mind about this virus is the clinical course for every person can be very unique. So we know that, based on some surveillance work in other countries, that maybe as many as 50% of people who are infected are entirely asymptomatic. So their disease progression is completely different than those patients I'm caring for in the intensive care unit. and those people that I take care of typically progress over a matter of somewhere between 3 and 5 days, although it's highly variable and often hard to pinpoint exactly when they're initially exposed. Typically, once you start getting very sick, you continue to get sicker and sicker, and the infection will sort of proceed down into your lower respiratory tract, into your lungs, and people will get pneumonia. And that ultimately results in something called acute respiratory distress syndrome. And that's really the main source of mortality for people who get this disease, because that requires them to be intubated and treated with a mechanical ventilator. And what we're seeing, at least from kind of early patients here in the United States, and certainly in some of the other countries, is that the average ICU admission for these patients is somewhere around 11 or 12 days. And so you can imagine that not only is that just a long time to be really sick, but that also opens you up to a lot of possibility for other complications and other things that can potentially kill you. In terms of, going into toxic shock, so that's not really something that's associated with this disease. Things that are associated with it, like I said, acute respiratory distress syndrome is common. You can have something called cytokine storm, which is less common, which basically is just an overexuberant immune response. And that causes a lot of undesirable physiologic changes to the body. And then I think the question asks, can you kind of have an undulating course? Typically, no. Usually, when you're getting worse, you continue to get worse until you reach your nadir, and then you recover, or we're unable to support you sufficiently, and your body is not able to tolerate the infection. But generally, you don't start getting better and then get a lot worse unless, for example, you get a bacterial superinfection, which is not nearly as common with this virus as, for example, influenza.
So I think the end of that is how long to develop immunity. Can you speak to that?
Well, it takes, you'll get an immediate immune response. This is Eric again. You'll get an immediate immune response, an inflammatory response, and that speaks to what Mike just said in terms of the cytokine storm. And then after a week to 2 weeks, you'll develop T-cell antibody. You develop T-cell response, B-cell response, and develop antibodies and important adaptive immunity that's important for controlling this in the long term.
In some cases, in a couple of reports out of China where they monitored the immune response in both adult patients and actually infants, they so there was one report of a 47-year-old woman who returned from Wuhan to Australia, was admitted with COVID-19 pneumonia, and she actually had antibody responses 7 days after her symptoms, and which it was basically about the same time that the virus load, so our ability to measure the presence of the virus, disappeared. And then she was able to have a full recovery. So no information about when the T-cell responses show up, or when they are going to show up, or how important they are yet for this disease. That's just one big black box for us right now as immunologists, but definitely also in the infants, the appearance of antibodies correlated very strongly with the disappearance of detectable virus in them.
That's really helpful. That's great. What is the timeline of various tests, RNA and antibody tests at local hospitals?
So now in the community, we have within the UCI hospital, we have a test with a 2-hour turnaround time. For outpatients, we have a number of different tests that we're using that have anywhere from a 48 hours to a 1 week turnaround time.
Is this the PCR test you're talking about?
Yeah, PCR testing. And the reason it takes so long is it has to be sent to the lab, certain reagents has to be run, then the results have to come back. So it's taking a lot longer than we would like. I did read today about a new test, a new PCR blood test that could have very rapid results, within minutes. That is not yet widely available. We don't have that available at UCI, for instance. The quickest test we have is a 2-hour turnaround time, and that's for patients who are very severely ill within the hospital.
Is that any better at the Navy?
I think the timeline on testing is very similar at most other institutions sort of throughout the nation. Anyone who listened to Gavin Newsom's address on Friday, he mentioned that turnaround time in the state of California can still be in many hospitals as long as a week. So it really does just sort of depend on the institution. As you can imagine, the farther away you get from large academic medical centers, the slower these processes are. We all happen to be, here near, obviously UCI, and I'm also affiliated with a fairly significant academic medical center. So we have that advantage in terms of turnaround time. There are definitely more rapid tests in the pipeline, 2 of which have just been FDA approved, or fast-tracked, a 30 and a 45-minute diagnostic test. So I think over the coming weeks, our diagnostic time is going to dramatically be reduced. But at this point, it still is, in many cases, a matter of days, which is a challenge on a number of levels, both in terms of isolating those patients and in terms of determining who needs what specific care.
And the rapid tests that are getting fast-tracked are based on the antibodies, as Eric was saying. So we will make, the first wave of antibodies are IgMs, or immunoglobulin M, and those could be detected quite rapidly. I don't know that we have a test yet for rapid detection of antigen, the way that we do for HIV. That I have not seen yet.
Not that I'm aware of, but.
Okay, so the last question in that area is, what are UCI specialists thinking about medications and dosage? And where is there a trustworthy Japanese source?
I'll just say that all of the treatment at this point is experimental, and it's still very early to be able to discuss the efficacy of different treatment modalities. A number of studies and trials are underway, some of which are at UCI. So right now, the care is what we call supportive, which maybe Mike can talk more about what is supportive care.
Yeah, that's absolutely true. That's the mainstay of therapy at this point, is supportive care. There are a couple of drugs that there is at least some sort of promising in vitro or early data. Those are both drugs that were developed for other purposes, but may have a role for the treatment of this infection. We just don't have enough to really say that they're particularly useful at this point. And the early data from the United States actually suggests that they're probably not particularly useful. And so we just don't know at this point. The randomized control trials are ongoing. Supportive care, really what that means is, as I alluded to earlier, when people get that pneumonia, the lower respiratory tract infection, placing them on mechanical ventilation to allow time for their body to heal. And then, supporting them with nutrition, supporting their blood pressure if needed with medications, keeping them calm and comfortable so that their metabolic rate is not elevated, and monitoring closely for other types of infections that, as I mentioned earlier, can develop while you're hospitalized and critically ill, or other complications such as blood clots and things of that nature. So it's really just allowing them time to fight off the infection themselves.
Thank you. Thank you for that. It's a lot of information to take in, I think, for all of us, but it's very helpful. The last two areas go to community safety and then media and government response. So in community safety, how do I safely check in on my neighbor? If I don't have a phone number and I haven't seen someone in a while, what's the best way? What's the safest way to do that?
So let me say I'm so encouraged by how our neighborhood and community is looking after one another. And this is a wonderful question. And in fact, even in this era of physical distancing, we need to make extra efforts to connect socially and supportively and emotionally. And so we know that those connections are indeed vital and important for our well-being. So certainly if you have a neighbor that you haven't heard or seen from, if you don't have their phone number to call them, going by and knocking on the door and standing on the porch and saying, hey, how are you? Are you there? Are you okay? That would be a perfectly safe thing to do. And so in these times, I think it would be a welcome, appreciated gesture of kindness.
I think that's great. I would chime in and say, I think now more than ever, it's important to go to the right and go to the left and go across the street. Even if you knock, if those are people you know or don't know, if you knock and take a few steps backwards, that's an important thing to do. Do you want to say something? Okay.
Let me just say that one of the things I've noticed, and it's a little troublesome to me, is that I'm picking up on when I'm out walking in the neighborhood trying to maintain social distance, there's oftentimes a look of fear in people's eyes when they encounter one another, and fear of contagion. And so what used to be a casual interaction, perhaps passing each other on the sidewalk, is now kind of charged with fear and suspicion and trepidation. And so I've tried to make a point of smiling, waving, saying hello as I pass people, because I think we need to be vigilant that this disease, this virus, doesn't turn us into being fearful of one another, because we know that as social beings, we need each other in order to survive. And so I hope that we can find ways to counteract this fear and to try to normalize or extend social graces to one another, to make sure that we're not sending signals of fear whenever we encounter someone that we may not know or be in our close circle.
Thank you. Hobart, maybe it is time to put those smile and say hi posters back out there. Thank you. Thank you for that. The other question is, when we take our dogs on walks, what is the risk that when we come back into the house, they're bringing COVID with us? It is okay for me to pick up a pine cone and toss it for my dog? I know it's really specific, and I can guess the risk of transmission is very, very low. But I'd like
Pinecones.
But I'd like to hear an actual answer from somebody who may already know.
Eric, do you want to take that one?
I know nothing about pine cones. Yeah, and what the immediate risk of picking up a pine cone is. I don't know. I'm just, from this standpoint, I'm not speaking as an epidemiologist. I just think there are risks like this that have to be so low that as to not be concerned about them. There's a point where we really need, and this is an issue, and it's an issue that we're all confronting, and Susan and I have exchanged more than a few words on this in the past couple of days.
Lovingly.
Oh yeah, right. Is how much is being sensible and being risk averse versus getting to the point where you're just we're reading about this, we're hearing about this, it's in our faces 24/7. Where does the being careful leave off and the move into fear and paranoia take over?
To Cindy's point, yeah. Yeah. Andrew, do you want to weigh in on that?
No, I have nothing really to add. I mean, the dogs, it's safe to walk your dog.
On a leash, of course.
All right.
Cindy, were you going to say something to that? Because this is really a point I think everyone around the country is facing, around the world even, is facing this particular issue. And I don't know if, anyone else Cindy or anyone else would like to weigh in on this.
Thank you. Yeah.
Again, I'm just going to go back to, this is primarily respiratory droplet spread. And so the chance of transmission on inanimate objects is low. And the longer things have been out, drying in the sunshine, probably the less likely they are able to transmit the virus.
You were just telling us about bringing our food in and washing our hands and cleaning everything off and burning the bags or whatever. I mean, it's
okay. I'm going to mute you in a minute.
Well, so you're weighing the degree of risk, and there's still a lot of unknowns that we're not entirely sure about, and I think that's part of what's fueling this intense anxiety and paranoia about going outside of your door or touching anything or greeting anyone, even from a 6-foot distance. And so I think we know that the further away you get from a respiratory droplet, the less likely the infection is transmitted. And yes, we could guarantee 100% non-transmission if we all locked ourselves up and had no human contact for the next, month or whatever it was. But we know we can't survive like that. We need to eat. We need to interact with one another in order to survive as human beings. So.
It's a really good point. You said it more kindly than Eric, but I get it. I get it.
Mike, I'm wondering how, I know you've got your questions,
yeah,
but Mike and Ilhem, wondering how you're seeing this. How's the Navy, how's the military dealing with this? Because we're talking about close quarters there as much as anything.
Yeah, that's a very good point and question. And that was actually one of the huge concerns about packing all those people on a hospital ship, particularly because we know that younger people are much more prone to be asymptomatic sort of carriers of this viral infection. So there is a lot of concern about packing people in. And we're one of the few organizations, I think, nationwide that's going about our business as usual. And, definitely there's enhanced precautions every day. When I walk into a hospital, somebody stops me from 10 feet away and screams at me and asks me if I'm sick and if I have any flu-like symptoms and if I'm coughing, if I've traveled. And if I answer yes to any of those things, I get redirected to the emergency room, where they will send me through a tent and screen me for whether or not I deserve a test for COVID-19. So, there's definitely a lot more intense assessment of people's risk than what we normally have. But at the same time, our job is to ensure national security. And so we just have to carry on our business as per usual.
Mm-hmm.
It's a really helpful picture.
So from your perspective, where we're living not under those kinds of circumstances, but what advice would you give for the community here at University Hills?
I think take appropriate precautions, but don't let the fear of what this could possibly do rule your life. I think we all, every day when we get out of bed, we assume some risk. And so I think it's important to keep that in perspective and also to keep in mind. that the vast majority of people who get this infection recover completely. You know, it's easy to lose that in the media hype that's going on, and there is a lot of, you know, obviously a lot of people are sick and a lot of people have died and will die, and I don't want to belittle that by any means, but it's so far significantly less worldwide than the average annual influenza mortality in the United States alone.
Thank you. That is a good perspective. So we have 2 more questions, but they go to media and notion of media and government. And I want to ask Michaela if you would help us with what's going on with the chats. I know you can all see the chats, but if Michaela, if you could facilitate that. Are there other questions that have not been answered by?
Yes,
by
there's been a lot of active conversations on the chat and a lot of questions. I think that some questions have not been already answered, so I may skip some of them in case the person that posed the question thinks that the question is still relevant. Please feel free to let me know, and I will pose a question next. So the first question is from Deborah. She actually asked at the beginning, what would the doctor wish we were doing, but we are not already doing, or not doing well enough?
Well, I would just say that adhering to the social distancing recommendations is really critical, because we know that the fewer number of people that get infections, the less likely we are to overwhelm the healthcare system and the hospital ICUs, so that we can actually care for the numbers of patients that are infected and have severe complications. So the social distancing, physical distancing right now is of paramount importance. We're trying to flatten that curve, reduce the peak of the number of people infected in our community, so that we can actually care for the ones who do become severely ill.
Perfect.
Thanks.
Anybody else wants to chip in?
Yeah, I think for the most part, you know, a lot of people are really taking to heart those recommendations, and there are definitely some pockets of younger folks who definitely don't seem to be doing that quite as well. And that certainly would be advantageous. But, you know, otherwise, I think most people are really doing their best to adhere to the various recommendations that have been put out by healthcare providers, the CDC, et cetera.
Deborah also asked, when you test positive for the flu, you're told to go home. Can you have both the flu and COVID-19?
You absolutely can. That would certainly be bad luck, and it would be relatively unlikely, but it's certainly not impossible. I mean, we routinely obtain what's called a respiratory viral panel on people during kind of the cold and flu season. And we not infrequently see people who have multiple viral infections simultaneously. So that can certainly occur. Obviously, at this point in the year, we've kind of passed the peak of influenza season, so that becomes less likely. Anyone I saw at this time of the year who had fevers and respiratory symptoms, I would certainly have a much higher suspicion that they have COVID, and say much less likely that they have influenza.
So there's a question that came up, and I don't know that we answered it. Can someone be reinfected?
No.
That's a really, really good question. These novel coronaviruses are still a mystery. There's some work that's been done on MERS, which is another novel coronavirus, the Middle Eastern Respiratory Syndrome virus. And for those particular studies, we can see antibody titers rise. So these are the immunoglobulins that are made by our B cells to protect from reinfection. they can see that those numbers start to drop after 1 year post-exposure, but we honestly don't know what the threshold for protection is yet. So for a lot of other diseases, we know exactly what antibody titer you need to have to be protected with high precision. But for these novel coronaviruses, we don't yet know what that magical threshold is, and how long-lived this immunity will be, and whether it will be protective for a long time or not. But
I was just going to ask Ilhem, what about people in China, people in Italy, people who are the earliest people to be infected? What is known from these individuals who've been infected, who've recovered? What is the likelihood of them being reinfected?
So that, so I think every single effort has been dedicated to dealing with the infection and dealing with the surge of patients, and very little basic science research has actually occurred. So, and in terms of immunity, I scour this literature every morning, and there's only one paper describing the immune response, and it went over 20 days. So there's been no real good studies of immunological memory, what it looks like.
There should be epidemiological studies that say, what the risk is of people being reinfected from a place like Wuhan that's already gone through, reached its peak, and as they're now worried about other people coming in and infecting them.
Right, yeah.
I haven't seen any case reports or epidemiologic studies that suggest that people have recovered from this infection, have been reinfected. Mm-hmm. Again, that doesn't mean it's impossible, or that over time, as that immunity wanes, that likelihood doesn't go up. But so far, I have not seen a report of that. I don't know if Cynthia has, but I have not.
Mm-mm. I mean, the only viruses the only viruses that I know of that are notorious for not building long-term immunities are the calciviruses, like norovirus. So you can get norovirus over and over and over and over again. For some reason, we don't really build very good immunity, long-lived immunity to it. But for the most part, the overwhelming majority of viral infections induce very long-lived immunity. The smallpox vaccine gives you an antibody titer that has a half-life of 90 years and a T-cell response with a half-life of 20 years. So, I mean, that's like the number of years for it to drop by half. Tetanus is over 10 years. Yellow fever, over 20 years. So I think we have a lot to learn. And I think somebody asked the question of what our government and other things should be. And it's not only to mobilize the healthcare providers, but also mobilize the scientists. It's actually, I will just say, this is my personal view, but I kind of wanted to send a note to the governor and say, okay, you've enlisted the National Guard. All of our labs are empty. You know how many qPCR machines are sitting on the UCI campus right now that could be running, maybe not CLIA approved labs, but could be running that QRT-PCR. How many scientists could be offering some new insights? And so, yes, we need to do the social distancing. We need to flatten the curve. We need to do all of that, but we also cannot bench our brightest minds. And between the UC system and the Cal State system, there's some really good immunologists and virologists, epidemiologists and microbiologists that have been told to go home. And I think that's a travesty, personally.
Well said, Ilhem. I couldn't agree more.
Before we go to that topic of the media and government response, Michele, I'll ask you again, are there other questions in there? I know there's a lot of active chat here. Are there things that...
Jenny asked a question which Ilhem already replied to in the chat, but I think that probably not everybody is looking at the chat. It may be useful maybe if she could reply also verbally. So the question is, do we know what % of people in the US receiving supportive care do successfully recover?
Yeah, so obviously, you know, the outbreak in the United States is still somewhat in its infancy, but if you kind of look at the overall data in the United States, the mortality rate is less than 2% at this point. You know, obviously, country to country, there's been some variance in that. And the other thing I think that's important to factor in is that there's a huge number of people who likely have COVID-19 who are never confirmed with a specific diagnostic test. I know specifically at my hospital, we send dozens of people home every day because their symptoms are mild and we don't test them. And that has been the protocol throughout the country for the last few weeks now. So it's hard to really know kind of what our denominator is that we're working with. We know that some other countries have certainly had higher mortality rates. For example, the mortality rate in Italy is approximately 10%. Now, again, we don't know the denominator there, and there's a lot of things that vary between their healthcare system and ours, including the number of ventilators per capita. Ours is about 10-fold higher than it is in Italy. And since this is primarily a respiratory mediated process, if you don't have the ability to provide maximal respiratory support, those patients are unlikely to survive when they have severe disease.
Well, as a statistician, to say that I would probably be careful about making these comparisons at this time with the data that we have. We don't have good data, so I'll probably be a bit more careful about that. But there is a question by Sandrine.
Can I just speak to that before you go on, Michele? I mean, your point, Mike, that I'm speaking anyway, but the issue is without the testing, we don't know what the denominator is. So
absolutely,
whatever that percentage is there, if we find out there's so many more people infected, which we expect, then the death rate or fatality rate is going to be much lower.
Correct. We're probably dramatically overestimating the mortality rate because we just don't.
But there is a question that I think is more important, at least from my perspective, as Sandrine actually is asking. So why is the seasonal flu that kills 30,000, 50,000 people a year, why does that not put a strain on our hospital system like the COVID-19 does?
Yeah, I think the biggest reason from my perspective would be that tends to be much more spread out over the course of, you know, somewhere in the range of 4 to 6 months, whereas this is all happening in a matter of weeks. And so obviously sort of at baseline, our healthcare system is operating with, you know, greater than 90% bed occupancy. And so it takes very little to throw us out of balance and sort of tax the system. And so that's the whole purpose of trying to flatten the curve with social distancing, is to make this a little bit artificially more like the way that influenza would impact our country in a more drawn out manner rather than all at once, given that nobody has any pre-existing immunity.
So with influenza, think about the fact that we have vaccines, we administer the vaccines, and our vaccines are kind of our social distancing with influenza. So, you know, the virus jumps from one person to the next, right? If it jumps from person A to person B, but person B is being vaccinated, then person B, that reduces the viral load. So the person B is not transmitting to person C. This is like throwing a match in a whole bunch of tinder, right? There is no natural roadblocks to the transmission here because we're all naive. We don't have the levels of herd immunity that we have with influenza. And even with the fact that influenza changes every year and we have to get a new vaccine every year, et cetera, there are still low levels of immunity. There's enough of us who get vaccinated. There's antivirals that are available, and the flu season is a little bit longer. And so it's the shape, it's the speed and the number of cases that hits the healthcare system at once.
So I'm going to jump in here. It's 8:59, and I reserve the right to ask permission that we continue for a little bit longer. Are you okay with that, Cindy?
I'm fine to talk a few minutes longer, but I also would like to say that during this period of time, it's so important that we take care of ourselves and our families.
Right.
And those are just kind of back to the basics of getting a good night's sleep and good nutrition and exercise. All those things are really important right now, because while we know the virus has arrived in our community, we know that we're going to be more successful in fighting it off with our own immune system if we're taking good care of ourselves.
Well said.
I would also like to just let people know that in the next few weeks, we're going to be seeing very sharp increases in numbers. And it's going to be really scary for people, because we're just really starting on this exponential part of the curve where the numbers are going to keep going up. And we're expecting that we're probably going to peak out here in Southern California somewhere in mid-April, mid to late April, possibly in May. And so over this next few weeks, there's going to be more and more infections reported. This is partly because we have greater testing capability. We know we have a lot of infections, but we haven't been able to diagnose and confirm them because of the limited testing. Now that we have more testing capability, the numbers will skyrocket for the next few weeks. It's going to be really scary. But those basic things that we're doing to take care of ourselves and one another, those remain so important and so fundamental. And it's part of why I'm so grateful that we have a supportive community and neighborhood. And I just want to thank everyone who's taken the time to put this together in this discussion.
We want to thank you, Cindy, for being part of it.
Thank you. So we had those last few points, and I wanted to make sure that I included those because I think there's an ask in there as well. And I think some of that depends on what this week looks like. So what could the media and politicians do about the current developments? And the ask is, could we include Katie Porter?
I just want to say I'm so proud of Katie and what she's been doing already. And so I think she's a champion for us, for middle-class people across the country. And so I think she's a very strong and powerful voice. I think we need consistent messages coming from the government at all levels. There are some inconsistencies right now. And so that just causes more confusion and paranoia and so forth. I've been so proud of Eric Garcetti, for instance, and Governor Newsom. I think they've been very clear in the messaging and what we need to do as a society, as a community. So adhering to those recommendations is really important.
Thank you, that's good. What could the US learn from other countries such as Korea, China, Singapore, Germany, about the model, their models? So Vera chimed in Germany, the mortality rate is 0.4, and there is much more testing than in the US. So what could we learn from those models? So that may be something that we pick up with next week. We may be able to bring in more people to talk about that next week. I think, Vera, you may have some suggestions about that.
Yeah, we have a German virologist who talks to the public every day an hour, and he works at in the Charité in Berlin, and he has good connections to a group in Göttingen, which develops a medication that seems to just kind of match the problems of the virus. So that medication will be distributed throughout Germany. I understand the military will distribute it, so every German will have it. So I sometimes feel like, listening to the situation here, that we really have to be very patient with developments here. I mean, we seem to have missed the chance of like contact tracking and things that are already in have helped in other countries. So I think Korea and Singapore are way ahead. And it's good to say that everything's fine here in the US, but I feel like I'd like to kind of go back to Singapore at this point, or to Germany. So I'm not really feeling that it's
I lost the last thread of what you said. It muffled. Say that again, please.
Oh, that might not really be a positive message. Maybe I'm muffled.
I see.
Realistic, yes.
Okay. All right. Well, thank you for that.
What we do with these questions that have just come up? We don't have time to deal with them today. Should we pass those along?
Let's take the questions that came up today and add them for next week. I will grab this for a discussion and see if we can get some of these questions answered. I don't want to take any more of Cindy's time. If you'd like to stay on the chat, we can discuss those here for a few more minutes, but I am going to agree with you. I'm going to go have my dinner.
Before we go, everybody.
Not done. Susan,
before we go, everybody.
Oh, what? I want to make sure that when I said we're going to go, not just yet. Cindy, I want to thank you very much for all of this. This is enormously helpful. It feels a little like a hug to the community. And Ilhem, they're right. It really, really does. It feels wonderful. And Ilhem and Mike, thank you as well. Thank you for everyone who chimed in. And Hobart, take us away.
Well, yeah, thank you everybody again for participating. We've had 70 plus participants this evening, and you're going to get the word out to the rest of the community, this important information. Some of it reassuring, some of it information that we need to heed and actively participate in being mindful about the things that we do. I want to remind everybody, uhills.org, we have an updated Caring for Each Other in the Age of Coronavirus page. So please check that out. Check out the Facebook pages. The links are there on the uhills.org page. We are doing updates on the listserv, on Nextdoor. So there are plenty of ways in which we will keep you informed as to things that are going on in the community and ways in which we can help each other stay safe. Thank you so much, Susan.
I want to be sure and let everyone know that this week and last week will be on our UHills YouTube channel as well. And that information will be posted on the Facebook and on the listserv. Thank you. Thank you, Hobart. Thank you, Cindy.
Thank you, everybody.
Thank you, Ilhem.
Good night. Thanks to all.
Good night.
Good night.
Bye-bye.
Thank you, everybody.
There.
No, it wasn't, but you can't stomp on my facilitating. Oops. Yes.